Okay, so I'm going to start now because it's 1 minute past 12, and I'm sure people are wanting to also find time to go and get something to eat as well. So I'm delighted to welcome everybody to the Health and Care Research Wales faculty's first webinar, which in which we're going to be hearing from Professor Deb Fitzsimmons. And Deb is going to give us an overview about why we all need a little bit of health economics in our lives. I'm really looking forward to hearing about it. Deb is Professor of Health Outcomes Research and Director of the Swansea Centre for Health Economics at Swansea University. I'm sure she's going to tell you a bit more about herself as she does her talk, but she is a senior researcher, a Health and Care Research Wales senior research leader, and is somebody who has really influenced health economics research in Wales. So thank you, Deb, for kind of leading off on our webinar kind of series. If I just go to the next slide, which is going to be handing over to Deb. If you have questions, please put them in the chat. They won't come up in the recording, so depending on how Deb wants to work this, we might see if we keep the questions till the end. Yeah. But also just put them in the chat as you're thinking about them so that you don't forget them, and then we'll come back to the questions at the end. So thank you very much, and over to Deb.
Oh, thank you, Monica, and thanks to all the colleagues in Health and Care Research Wales who've arranged these seminars. I'm really delighted. It's always nice that health economist gets to go first. We usually come in last if any of you worked on research projects, and I'm really delighted that on behalf of Professor Deb Fitzsimmons, Dr. Emily Holmes, who I think is also here today, and myself, that we get to present the first of these seminars. It's a really privilege as well, sort of from a personal viewpoint. I've been the personal beneficiary of having support in making the transition from my PhD to postdoc career by gaining a fellowship almost 21 years ago now. And it was really such an influential moment in my life. It's really sort of harnessed, my ambitions in terms of research, but also that you have that opportunity to move beyond your PhD. Now, saying that, how I managed to go from cancer nurse to Professor of Health Economics, I'm not quite sure, and it's a bit of a long story. But I think one of the things that sort of characterizes that is being collaborative, being curious, and probably being a little bit crafty in terms of having such a rewarding career to date. It was very unplanned to move into the world of health economics, but I've thoroughly enjoyed that. And so that's where I want to start today, really. I remember when somebody asked me to become more involved in health economics. I mean, I came from a reasonably related background. I've had my PhD and postdoc to date had been in patient-reported outcomes. So me and the quality adjusted life year sort of got on fine. I had experience mainly in health service research, including clinical trials, and allegedly I was okay with numbers and sometimes words. But I haven't come from economics from that traditional route. I had to learn that. I've had to learn new language, new concept, new methods, new ways of thinking. But I think to say that that's been such a fantastic part of my career to date, that you have that opportunity to stretch out and learn new things. So I'm going to take that basis then to introduce you to health economics in a way which I hope makes you feel comfortable in having a little bit more insight into what we do and the sort of questions that we ask. And also where you can get some further advice and support so that we hope that health economics can help you a little in both your research and professional lives. Okay, so one of the earliest things that captured my attention was about the sort of nuts and bolts of health economic theory and principles, and they really drill down into things that we do in our daily lives. We're all having to make difficult choices. And one thing that I learned as well as being a parent is the issues around the challenges of supply and demand. So can I just illustrate you with a conversation that I had with my daughter? Hope some of you may already have similar conversations in your lives. So it went a little bit like this. My daughter came to me one day. I really need a puppy. There are puppies looking for homes. She'd found out that she'd signed up to most rescue centres in South Wales. She was willing to pay for this puppy, both now and in the future. She wanted to reduce inequalities in the puppy world by adopting one from a rescue centre, so that to give that puppy a fair chance of having a good life. There'd be so many benefits to both her and us as a family in getting this puppy, and that she'd be willing to sacrifice other benefits in order to invest in this new puppy. Now, faced with this dilemma, what would you do? I'm sure most of you'd be saying no. But I just wanted to turn this sort of situation into some of the questions that a health economist might pose. So, thinking of this rationally, transparently, with these limited resources as a family, will the investing in this puppy bring the most benefit or utility to our family? What other benefits will be forgone if we chose to invest in this puppy? For those of you that have dogs, especially at the puppy stage, I'm sure you're all aware of the demands on the resources, not just in terms of money, but in terms of time and other things that they need in order to fulfill their lives. And importantly, how can we make a decision about the value of this puppy in an objective, transparent and justifiable way? So what I'll do now is I'll stop talking about the animals in my life and get on to the business that we're all in. And through our research activities in health and social care, and I include public health very much in that, we're trying to improve the health and well-being of our patients, our populations, through the delivery of effective and equitable care. Now, these are very important to health economics, and we'll talk through some of these a little bit later. But we're going to talk about this in terms of efficiency and where economics sits. So health economics is a branch of economics, which is a social science that studies the behaviour of individuals, governments, firms and other organisations when faced with this principle of limited resources. And so we start with the basis that there will never be enough resources, whether that be in health or outside health, within our daily lives, across society as a whole, to completely satisfy all our human desires and wants. So those wants and desires are unlimited, but the resources that we have to try and manage those wants and desires in terms of our human resources, our financial, capital, environmental, etc., are very limited. So when people think about health economics, people tend to think about some of the methods. Can you do a cost-effective analysis? What is a cost-utility analysis? And Dudrig and Emily will talk through some of those next time. But I really wanted to take us back to basics in terms of some of that thinking that we need to do in terms of making very difficult decisions about how we allocate our limited resources within healthcare. So does it matter? Well, yes, it does. Because resources are scarce. And I don't think any of us need any reminder of that in today's world. And I'm sure that if we look at the press, the media today, we'll see numerous examples of that. And so we have to make choices and decisions and prioritise what we need to do because those resources are scarce. And scarcity means that we cannot do everything we would like to do. So we have to make those choices. But those choices, particularly when we're making difficult decisions about how we allocate our resources for people and populations, need to be made explicitly. And so as health economists, one of the criteria for choice that we use is something called efficiency, which is maximising the benefit of the available resources that we have. And let's face it, if it was a perfect world, I wouldn't be talking to you here today, and you wouldn't need health economists. Because if we lived in the perfect healthcare system, oh, sorry, can you just go back to that slide? Thanks. We'd have the ability to meet all needs fully and immediately. But let me take you back then to those fundamental principles of supply and demand. So we are living in a world where there's increasing unmet need. Higher demand on an ageing population with increasing life expectancies. And it's not just about increasing life expectancies, but those inequalities that we're starting to see and indeed widening, particularly in terms of having years of healthy living. Decrease in health of the population, for example, the impact of obesity, low activity levels, stress. We're all now starting to see the consequences both intended and unintended as a result of the COVID-19 pandemic. And those are exacerbating some of the sort of stresses and strains that we already had in a very pressurized system. In terms of that supply side, then we know about these issues around workforce and trying to just keep up that demand and that ever increasing demand on all these needs. We see changes in NHS budgets, okay, and how to use those wisely in order to deliver the best value of care across so many competing needs and preferences. We also live in a world where there's increasing and high cost technologies. So should we allocate our resources to supporting a high cost cancer drug, or should we use that money to invest in a public health strategy which would possibly benefit more people? And of course, we have increasing expectations, both as consumers of healthcare, but also as professionals, and what we want to do in terms of deliver the best care possible to people in order to let them live the best life possible. So why do we make these choices? Well, you know this, you're in the business of producing health and delivering healthcare. We need to do it for the good of the patient, so that we're not exposing them to harm and trying to give the best and most effective care possible to improve their outcomes and experience. We have to look about improving efficiency, using our resources in the best way possible to get the maximum benefit, and also through that improving the quality of the care that we deliver. We need to reduce waste. We know that many of the things that we do are still untested in terms of evidence, or indeed might be causing harm, and that's just increasing waste in our systems. We have to address things like equity and equality to try and make sure that wherever possible we're giving everybody a fair slice of the pie, and of course avoid harm. But simply because there is not enough to go around. There are not enough resources in order to deliver all the things that we possibly want to do within our healthcare system. So what is health economics and why do we need it? So I want to suggest that health economics is much more than its methods. It's a specific way to view the world. It's a way of thinking. And so it's really important that we think about this as a branch of the economics, so it's rooted in strong economic theory and principles, some of which have been adapted to look at the specific economics around the production of health, and also we've, as a discipline, making advances all the time in order to expand and increase the rigour of what we do in terms of our discipline. It's really a way of thinking, and today is really focused on those sort of key concepts which may help you think about things a way that the health economist does. It's a set of techniques, and that will take us into those methods, and those are things that Emily and Duthrig will focus on at the next seminar. It's also an aid to decision making. I think it's really important to ensure that we're clear what health economics isn't. It isn't a bean counting exercise. We're not just trying to count up the pounds, shilling and pence. We talk about costs. We'll talk about costs and what that means to health economists in a moment, but it's not just looking at money as our resource. Indeed, money is not the resource that we're really interested here. It's not to be a money saving exercise. Yes, we might be able to demonstrate that your intervention or your service may deliver some form of resource or cost savings to the NHS and to society, but we're most concerned about maximising benefit, and sometimes you have to spend a little in order to get that bigger gain, and that's where cost effectiveness comes through, and Emily and Duthrig will talk about that again at the next seminar in a little bit more detail. And we don't view costs in the same way as, sorry, could you just go back to that slide? In the same way as a finance person. Finance are looking at the money flows in and out, whereas health economics, when we're talking about cost, we're looking at in terms of the benefits that foregone, and this core concept of opportunity cost sort of underpins a lot on how we think, and we'll try and incorporate that in trying to look at how we get the maximum benefit for the resources available. So what we're trying to do then in health economics, and if we assume that the aim of society then is to maximise benefits from these limited resources, what we're trying to do then is consider these sort of alternative costs of that sources of actions and look at our costs and benefits for both the NHS, the social care, across public sector and society. And we're really focusing here on trying to achieve that efficiency. And again, not to go into the sort of economic theory behind it, but efficiency is achieved when it's not possible to reorganise resources and achieve more benefit. That is, the opportunity costs have been realised. And so every healthcare intervention has a cost, i.e. it requires resources. Spending resources on one interventions mean we cannot invest them in others. And we need to choose what we spend our scarce resources on. Now that could be, do we invest in this new drug, or do we invest in that public health vaccination programme? Very important decisions, very difficult decisions. When we talk about these in terms of efficiency, we talk about three main types. When we're looking at, say, an intervention to another, we're often talking in terms of technical efficiency, the maximum possible improvement of an outcome obtained from that given set of resource inputs. So here we may be comparing one dose of drug against the other. The next is productive efficiency. So we're choosing different combinations of resources to achieve the maximum health benefit through a given course. So, for example, that might be to change the screening age or for Down syndrome, so that you're carrying out fewer amniocentesis, but moving towards more biochemical testing. So that might be ways to look at efficiency there. But what we're really trying to look at and move towards in terms of how we look at our limited resources across the healthcare system as a whole is allocative efficiency, achieving the right mix of healthcare programmes which have different health outcomes to maximise the health of society. And this is the difficult one. How do we make sure how we allocate resources, maybe moving it from the care of people who are at the end of life, possibly to allocating resources to people with mental health concerns. So efficiency is all our concerns. We're all dealing with limited budgets. We're all having to make difficult choices. So I just want to then put it in terms of maybe our ethical responsibility. Sorry, can you go back? Thanks. And I just want to share with you the words of Alan Williams, who's one of the founding health economists in the UK. And he just reminds us that in a system with limited resources, health professionals have a duty to establish not only are they doing good, but they are doing more good than anything else that can be done with the same resources. So as a health economist, I'd argue that we've all shared this sort of moral and ethical responsibility to be efficient. Okay, so when we're allocating resources and we're trying to move towards this efficiency, then we're trying to assess that extent to which the allocation of the limited resources maximises the benefits for society. And the most efficient solution to a healthcare problem is the one that makes the best use of the resources available. So it's about looking at those opportunity costs and looking at ways that we try and drive efficiency into the way that we deliver our healthcare interventions and services. And that's where health economics comes into healthcare research policy and practice. We focus on efficiency. We use different methods, which we'll learn about next seminar on how to drive that. But I also want to put it into context that we shouldn't forget about equality and certainly not equity. And so it's important that when we look at our drivers of efficiency, we also look at this in terms of our distribution of equitable care. Tensions can arise. We shouldn't ignore these in trying to pull together a way that makes and delivers a just and fair and efficient system that delivers the best outcomes and experience for people and populations. So as health economists, as health economics, what we're trying to do then is help you to derive the best evidence possible to make these difficult choices. And so that's where health economics can come in to helping you across your research life and evaluation life cycle. It may be just to give you some good advice, or it may be to come in and conduct a robust cost effectiveness analysis to help deliver that evidence in order to quantify those costs and benefits. So when should you start thinking about health economics? First of all, is obviously think about your research question and thinking of all the things that we're doing, and also where your sort of destination in terms of the impact that you want your research to make. You know, how do you want this to be adopted? Is this about trying to derive the evidence to make policy or clinical decisions? How would health economics fit into this? Does it add value to your research programme? And in looking at your research programme, where's the best time for health economics to come in? We don't want to be too late, but we also don't want to be too early to the party. And so it's important to have that conversation with us as health economists to think about where best placed, if you think health economics can add value to your programme, where that value can most be derived. For example, is it to come in once you've designed a safe and acceptable intervention? Does the funder expect or requiring inclusion of health economics? Many funding schemes do. For example, the NIHR Health Technology Assessment has an explicit requirement to include health economics in most, if not all, of their in their applications. However, if you looked at the NIHR EME scheme, the health economics is deliberately not afterthought. So it's really important that you think about where health economics comes in. For example, in the Health and Care Research Wales programmes, such as the RFPB and Health Research Award, having that conversation with a health economist will help you decide whether or not you should indeed prioritise health economics into that funding application, bearing in mind the budgets available. And that's really important. It's not about paying lip service. It's not to put health economists in because you think that doing that will get you the bid, but it's really about that value and added contribution that health economics can make to your research programme at that particular point of time. And next time, Emily and Duthrig will talk about some of the sort of different methods, but just to make you aware that it's not just about finding questions around the cost effectiveness of interventions or services, but health economics can help you in other ways. For example, it might be about eliciting preferences for different services and interventions. It may be to support the prioritisation of different services and interventions. So, for example, using methods such as programme budget marginal analysis. So we've got a sort of repertoire of skills and toolkits up our sleeves to help you. It may be, if you're looking at more sort of towards more public sector or beyond that sort of traditional and health and social care boundaries, it might be concerned about looking at the social value of services and interventions. Or our work can also then span into more methodological development, for example, in helping design and interpret patient-reported outcomes. So it's health economics has a lot of areas which just might help you in terms of helping you design and conduct your research programmes as you go through your research careers. And just to put this in context, I can see that Graham is going to be delivering a session in April looking at the MRC framework in relation to process evaluation. But I just want to quickly draw attention to the revised MRC framework that was published a year or so ago. And now that explicitly puts a health economics question sort of right in the centre of those core elements that we should think about when designing, conducting and evaluating complex interventions. And so the question that you need to ask is, do the effects of the intervention justify its costs? And that's where health economics can come in. And I think certainly what I've seen over the past few years is health economists are coming in earlier into the design stage so that we can start asking some of those critical questions and start thinking about how we make health economics deliver the evidence that you'll need to ultimately ask that question that the MRC has posed here. And I'll let Dyfrig and Emily talk about some of those ways that we use health economic analysis alongside clinical trials. But I just thought I'd just draw your attention to some other types of ways that that I've used health economics to support research. The first one is the placement trial, which is being conducted by Dace Poscant and colleagues based at Aneurin Bevan University Health Board and colleagues at Centre for Trials Research. So I came in whilst it was being designed as a feasibility study. And this was really focused on about whether or not you could undertake a randomised controlled trial of this new catheter in this population. So it was far too early for a formal health economic analysis, but we embedded a small but important health economic components, and we looked at these four questions. First of all, what impact would the intervention have on the pathway of care? This was a sort of perioperative intervention. It was designed to, or would be designed to support pain relief in people in the sort of immediate post-op period. But when we look at using resources, we shouldn't just be sort of focused on that particular point in time. As health economists, we're very concerned about looking at things over the longest time horizon possible, so that we get and can capture all those costs and benefits as people go through their pathway of care. So we looked at that in quite a lot of detail to try and map that out in these initial stages. It was really important that we understood what the main drivers of resource use would be and how we went best to collect those. So yes, of course it would be things around hospital stay, but the other thing that we were interested in seeing if there was potential changes to is whether or not, as a result of having good pain relief, people's functioning would be better, and they may get that benefit then later down in the lines as they recover quicker from their operation and rehabilitate. So looking at things in terms of what those drivers of resource use were, but also in terms of quality of life. And that took us into then, well, if we're really interested in measuring quality of life, how can we do that best in order to try and maximise looking for differences that will help us derive that ability to look at effects relative to cost. And importantly, what would be the most efficient design for a future health economic analysis. And I'm pleased to say that that work has led to the placement trial, the full trial, which was to be funded by the NIHR Health Technology Assessment, and that trial has literally started in the last couple of months. So it shows a good sort of success story about some early stage considerations of health economics helped the team design a larger multi-centre trial, which is now going to definitively look at cost effectiveness of this placement intervention. And then to give you sort of a very different example, so that one focused on using some early stage thinking and preliminary methods leading on to the more formal cost effectiveness analysis. But as health economists, we also look at things in terms of trying to draw together from more observational studies or real world scenarios to look at using routine data to try and understand the cost effectiveness of current pathways of care, and when we try and put new innovative ways in place. So we'd like to draw out the work that we did with colleagues in Swansea Bay University Health Board. And this was looking at a very local service. It was a pilot service looking at introducing a rapid diagnosis centre into the Swansea Bay University Health Board area to try and expedite and improve the diagnosis at an earlier stage, the people who were coming with vague symptoms, so people who were currently underrepresented in the current sort of pathways of care, to try and to help get them through and get them diagnosed, and hopefully then improve their outcomes overall. So we drew on real world data here, and we asked whether this new rapid diagnosis centre pathway would represent a cost-effective pathway of care compared to what was happening at present. And what we focused on in here was trying to look at understanding what that impact of reducing waiting times to diagnosis would help. It certainly did, and what it did was significantly reduce the time that people were waiting to get access to particularly CT scans and getting a diagnosis, and that stopped a lot of the bounce around the system, which ultimately was accumulating more and more resources. And we also looked at it in terms of patient benefit. So looking at it in terms of that quality adjusted life year, which is looking at both the quality of life and also the survival outcomes of those people that were diagnosed. But that was only part of the question. And for many of you that work in a system under strain, it was really important to understand. So if this was a model of cost-effective care, what would the service capacity have to be in order for that service to remain cost-effective? How many clinics would need to run a week? How many patients would need to be seen within those clinics for it to remain a cost-effective service? And through this work, which was very much about local application using real world pathways and routine data, helped us develop the case for these clinics to be rolled out. First of all in Swansea Bay, but I'm pleased to say that this work is now being rolled out across Wales. And our analysis was just a small but important part of trying to deliver that evidence to inform real world delivery. And so that's a very whistle-stop tour. It's a Monday lunchtime, and I need to be efficient with my time as well. But I'd like to take this opportunity to introduce you to Health and Care Economics Cymru, which I'm really, really proud to direct with my co-director, Professor Rhiannon Tudor-Edwards, up in Bangor University. We have been funded by Welsh Government via Health and Care Research Wales to help colleagues, other researchers, and we're in the business of leading and supporting good, excellent health economics research to benefit the people and population of Wales. So we get involved in a number of collaborations and partnerships. The list is endless, and I know that some of you on the seminar today, I've worked really closely with you, so it's a delight to see you here today. But please go and look at those that website as well, and it'll give you there's a great animation there that will tell you a little bit about what we do and also how to get in contact with us. And I think the main message then is to say, please get in touch with us. Very happy to talk, very happy to discuss your idea with you. We're very good at telling you when health economics is needed, but also when you perhaps it's probably not quite right for you. But please do not hesitate to get in touch with myself and colleagues through Health and Care Economics Cymru. So in essence, can you afford not to have a little bit of health economics in your life? I'm afraid that in today's society, and you know, the reality is that we're a necessary part of many of the research problems that we have to seek solutions to make sure that we can deliver efficient and effective and equitable care to our people and populations. And just to end on it, did I follow my thinking? No, I didn't. So the decision was, the puppy was adopted, and I should have known better, because as you can see, it was the third time that I hadn't quite got round to applying the principles that I've preached today to the practice of my everyday life. So Bertie joined the family, and he's now a very large and very boisterous 1-year-old. So thanks ever so much for listening.
Thank you so much, Deb. That's really a really lovely overview of kind of health economics. We've got a good range of people here. I wondered if anybody has any questions. There hasn't been anything come up on the chat, but does anybody have any questions for Deb? Not Sarah.
Hi, Sarah.
Hi, Deborah. Thanks very much. Really interesting presentation. I work in Cardiff. I'm an anaesthetist, and I'm very close to one of my colleagues called Fiona Brennan, who does a lot of work around sustainability. And I just wonder how, going forward, you're integrating sustainability and environmental impact into the economic analyses that you do, and what sorts of things we should be thinking about when we're starting to put together our research projects with our interventions to measure those to support that.
Yeah, no, thanks for that. It's certainly gathering pace, and it's a question that we've been asked, I think, in the last year, particularly to try and embed some of that. I think in the discipline we've always focused on efficiency, so that is so things that we're doing is trying to bring out to those wider environmental impacts. For example, looking about, well, if we deliver the care, our service or intervention in that way, what would be the impact, maybe looking at carbon footprint as well. I work with the Asthma Centre for Applied Centre for UK Research, and that's certainly something that's coming out, and some fascinating stuff coming out in terms of the health economics of environmental interventions. I think there's a discipline we're still learning. And I think it's really to have that conversation and to test and develop some of those methods in order to help answer some of those questions. Some of that will go into some of the wider impact. I mean, sometimes we're constrained on time and the horizon that we have available, but I introduced you to that RDC, and that was a model, an economic model. So if we use some more economic modelling techniques, then that allows us a little bit more flexibility to try and explore and address some of those questions, so that we can not look about the benefit now, but also what that benefit can be in the future. So I think it's here to stay, and I think that's something that will gather a pace. So very happy to have a chat about it.
Great, thanks.
Okay, thank you. Are there any other questions for Deb? If not, Deb, I've got a question for you. And forgive my naivety about this, but I'm hearing a lot about value-based healthcare, and I'm a bit confused about value-based healthcare versus health economics, because I understand the health economics, but I don't really understand the differences. So I'm sorry if it's a naive question, but maybe you'll be able to answer.
It's not a naive question. I think it's a very perceptive question. There are, I think, certainly in terms of some of those core concepts are similar. I think the way that we may approach answering some of those questions are a little bit different. I would think that there are some differences in the way that we would apply some of those methods in particular, which sort of take us back to some of those core economic concepts. For example, looking at value-based healthcare is very focused on averages, and we're more focused about differences around the margin and incremental. So there are some really subtle differences. I completely agree. I think sometimes we talk about these things thinking that they're the same, but they're not. So I think what would be helpful is that there's sort of better communication engagement between us as health economists and with our colleagues in the value-based, because there's probably more commonalities and differences, but I do understand that at the moment it feels a little bit difficult to understand what they might be.
Okay, thank you. So I guess the
that
message
was a diplomatic answer, wasn't it?
Well, no, I mean, I think the message for our members is that they approach the idea about, value, costs, benefits in a different way, and that it is there are two slightly different approaches. And it's important to try to unpick that.
Absolutely. And I think next session, Emily and Duthrig will take through some of the frameworks that we as health economists will do. And it's very much about that comparative analysis of alternatives, costs and actions. So it is about looking and building in some of those core principles. Talked very much about efficiency and opportunity cost today, but there are other ones as well, which sort of, you know, define us in terms of our health economic analysis and methods.
And I suppose my other understanding is about value-based health pairs. It's also about, that feels as if it's more about a personal perspective and the use of patient-reported experiences and outcomes.
Yeah.
Whereas you looking more at costs.
Well, it's that. Yeah, there's like I said, we use the same things, but I think some of the ways that we would apply it to us are slightly different. So I mean, we're concerned with patient benefit, patient quality of life, but we will look at that next time in terms of how we derive that in terms of the utility, which is quite limited. We recognise that. Certainly the work that I'm doing at the moment is trying to bring more of that health economics thinking into maybe widening our benefits. So we talk about health, but actually should we be talking about health and well-being? And so we're getting more into that, maybe looking at not just cost per quality per se, and even nicer coming round to that, you know, whilst that's preferred, there are maybe other measures of benefit that are really important to include. And when we can talk about some of our other methods that might help us to capture that a little bit more widely than the sort of narrow focus on health.
Okay, brilliant. Thank you. Are there any other questions from anybody else? Otherwise, I think, Emma Reese. So Emma's put something in the chat.
We'll just get
for those interested in environmental costs, I recently came across this organisation whose website was very helpful, which is sustainablehealthcare.org.uk. And there's been a thank you from Ashra.
Thanks, Ashra.
For kickstarting the seminars, and I know. Thank you very much, Deb. We put you on the spot. So
it's okay. It's good now. I was like I said, it's just very nice for health economists to be first out the gate rather than being at the end, bringing in the data and findings right at the end. So
yeah. Okay.
So I've got just one more question. I think if you can just squeeze it in.
How important are PPI in health economics work, and how closely do you work with PPI?
Okay, so I'll answer this correctly because I'm working with Kerry on her Elect 2 trial, so I best try to be the best health economist I can to support her. It's really important now. It's something that we've learnt. It's as we've emerged in Health and Care Economics Cymru, one of our core work packages is PPI involvement engagement. It's actually been incorporated now into our own sort of standards of international good practice. So the Cheer statement that was re-released about a year, 18 months ago now has a specific criteria around PPIE, and certainly I just absolutely value it. So I come in probably earlier than a lot of health economists and actually want to talk to people about the resources and understand it from their sort of own viewpoint in terms of what's important and relevant to collect. So I very much I do quite a lot of programme grants at the moment, and that allows us to put some really great sort of developmental work in terms of working and engaging with PPIE. And at the end of the day, if I can't communicate as a health economist to people and populations, then you know I really ought not to be doing the job. So I think it's really important that and why I wanted to do today was just start talking in this everyday language about things that are fundamental but core to how we deliver healthcare services and interventions.
Thank you. So very important.
Very important.
And you've got lovely dogs.
Do you want one?
Okay, so if there aren't any other questions, if people do think about questions, you know, after the time, if you send them along to our faculty team, we can pass them on to Deb. But for now, I'm going to say thank you very much to everyone. It's been a really lovely start to our webinars, and we'll see you all again in a month for the next one. So thank you very much.
Okay, thanks all. Thank you for attending, and have a lovely lunch if you've not done so already.
Thank you. Okay, bye-bye.
Bye.